And welcome to our members webinar this afternoon. This is Pat McBride and I'm hosting the session for Alison Milne, who will be presenting. The webinar today will run from now 1:30 to 2:30. So we want to make our information more accessible and share it with a wider audience, hence we've started these webinar sessions. And we have amazing patient services for you apart from the webinars, helplines, our nurse helpline, helpline emails, telephone buddies, and our new text service, which will start at the end of June. Thank you to everyone for joining in today. Your membership to us is absolutely invaluable. So today's talk is by Alison Milne, our endocrine specialist nurse, who many of you may have spoken to. And she will be presenting to us about adrenal insufficiency and sick day rules. So this will be of interest to steroid-dependent patients who take hydrocortisone or prednisolone. Alison will explain about the role of cortisol and the need to increase doses in illness and stressful situations. She will also talk about emergency hydrocortisone injections and adrenal crisis. There will be an opportunity for you all to ask questions to Alison at the end of her presentation, and these will be in the form of typed messages. So what you do to ask a question whilst the webinar is in process is at the bottom of the screen on the left-hand side is a send button in red. If you press that, then you type your question. Alison will do her utmost to answer as many questions as she can at the end. We will also have this webinar recorded so that you can watch it once again. Our Alison has been with us for almost 10 years. And she has worked with endocrine and pituitary patients for many years before that and since in her hospital role. Well, I'd like to hand over to Alison and thank you all again for joining in. Alison, would you like to start?
Hello, good afternoon. Thank you, Pat, for that kind introduction. Welcome to you all for joining us this afternoon for our webinar, and I hope it'll be of some benefit to you all. So as Pat has described, what we are planning to do is to cover in the allocated time to help you understand adrenal insufficiency, the causes of secondary adrenal insufficiency, steroid replacement education and the sick day rules, how to recognize an adrenal crisis, and emergency injection advice. So I thought I'd give you a wee bit of history. And Thomas Addison graduated from Edinburgh University and he worked in London. And in 1855, he described a clinical syndrome which was characterized by wasting and hyperpigmentation and identified it as its cause as destruction of the adrenal gland. So therefore, this was when Addison's disease was discovered. But replacement glucocorticoid therapy, so that's your hydrocortisone, did not become available until 1949. Now just think about that. That's actually not that long ago in our history when you think about that. So we're talking about adrenal insufficiency. Cortisol is essential for life. It allows other hormones to induce certain effects, but in a controlled manner, and it is important in maintaining metabolic balance and also the body's response to stress. The need for steroid replacement therapy results when inadequate adrenocortical function happens, and this may be due to destruction of the adrenal cortex, which is known as Addison's disease, which is primary adrenal insufficiency. And secondary adrenal insufficiency is due to disordered pituitary hypothalamic function. And I will explain this a bit further for you. So most of you tuning in today, I imagine, know about your pituitary gland. So I wanted to show you the basic anatomy of the adrenal gland. And as we've said, the need for steroid replacement therapy results from inadequate adrenocortical function. So here I just want to show you the difference between primary and secondary. And many of you may know this, but for some new people who don't, I'll just show you here is what is the normal production of cortisol. So you've got your CRH, which comes from your hypothalamus, and that's corticotrophic releasing hormone. Then your pituitary gland sends out ACTH, which is adrenocorticotrophic hormone, and that's sent to the adrenal glands, which produce out cortisol. So in primary, we still have our CRH and our ACTH, but our adrenal gland can't work. It's stopped working and won't produce out cortisol, and therefore that's the primary Addison's. And in secondary, what happens is in pituitary disease, we don't get the ACTH being sent from the pituitary gland to the adrenal glands. So therefore, that's what makes it secondary. And we also have hypothalamic disease, which means that the initial signal from the hypothalamus isn't being sent. So these are our secondary reasons for steroid insufficiency. So we move on to the causes, and lesions of the hypothalamus or the pituitary gland, that causes us to have problems with our steroid use. Also, infection, inflammation, long-term use of steroids. So people that have had high treatment doses of steroids for the likes of asthma and rheumatoid arthritis, they can be steroid deficient, and that's known as iatrogenic. And also after radiotherapy, and again, people after Cushing's disease, after removal of the tumour, and that causes them to be steroid dependent. So the treatment, excuse me, and management of adrenal insufficiency, the outcome is the same, but to be medically correct, if you have a pituitary condition, remember what I'm saying, this is secondary adrenal insufficiency. Many people say, oh, I have Addison's, when actually it is pituitary, they are secondary. But people are replaced by steroids the same, and the rules of how to take them are the same. So we have hydrocortisone, which is our sugar steroid, and we have something called fludrocortisone, which is our salt steroid. And in people that have Addison's disease, the primary, they need to take both these medications, whereas generally people with secondary pituitary adrenal insufficiency don't require fludrocortisone because that part of their adrenal gland is still working. Unless in some patients who have had Cushing's disease and they have had to have pituitary surgery, then followed by both their adrenal glands removed, they then will also need fludrocortisone. Now I know that many of you may be on, majority of you will be on hydrocortisone, but some of you may be on prednisolone, and indeed there might be a rare few that are on dexamethasone, and some indeed may be on the new long-acting drug, Plenodrin. But when I'm talking about this today, I'll be referring to hydrocortisone, but the rules apply to whatever replacement you are on. So we're moving on to replacement hydrocortisone therapy and the sick-day rules. So hydrocortisone tablets we're going to speak about. As I said earlier, it's essential for life, and the importance of this medication I can't stress enough. Most people are on an average dose of 15 to 20 milligrams daily, and the dose is divided between 10 milligrams on rising, first thing in the morning, and 10 milligrams at tea time between 4 and 6 p.m. Now this can sometimes vary. Some people have a lunchtime dose, and indeed the steroid can be individually tailored to their needs. So reiterate, it is different for most people. And I know that a lot of people are experimenting with their steroid doses, and some people take them varied times over the day. But the majority of endocrinologists still use the conventional dosing regime, although we try now to use the minimum replacement doses that the body can manage on. And that seems to be about 15 milligrams now. So many of you who have been members for a long time or have been steroid dependent for a long time may indeed be on slightly higher doses. But nowadays we do try to use the minimum dose that is beneficial. So steroid replacement education, many of you here I'm sure have heard me or many others tell you the do's and don'ts of taking your steroids, but it's something you cannot be reminded of too often. And indeed, every time you hear it, you may pick up another important point or remind you of an important point. This slide really shows the absolute minimum that you should know and understand, and it speaks really for itself. We speak about our sick day rules, and that is at any sign of infection, feeling unwell, bad cold, flu, then you double your dose for at least 48 hours. Now when I say double your dose, if you take 10, 5 and 5, then you take 20 milligrams, 10 milligrams and 10 milligrams. You absolutely double each dose until you feel well. If you're unable to swallow or keep your medication down for whatever reason, then that is when you require an intramuscular injection or intravenous injection if you are in hospital. You should all wear a medical alert bracelet or necklace or have some identifier on your body that lets people know that you are steroid dependent, that you require hydrocortisone in an emergency situation. And hence carry some written information if you can, many of which is on our website, free to download. The Pituitary Foundation Hydrocortisone leaflet. You get a steroid card, and you usually get a steroid card with your medication when you pick it up from the chemist as well. And it is always advisable to carry this in your purse or wallet. So never run out of your medication. Always have at least 4 weeks supply, and we know that we can have difficulties with our doctors and our pharmacists for not getting a big enough prescription. But I say at least a month's supply, and that is so that if you have to double up, you always have plenty, because you imagine you're going to go through your tablets quicker if you're doubling up. Wear a medical alert bracelet, as I've mentioned, and carry your steroid card. A very important thing is to inform your work colleagues of your condition, because if you're in a work environment, especially if you're working manually and with machinery, if any accidents were to happen, then they should know that you are steroid dependent and what to do in the event of an emergency. And keep your medication everywhere. Have some at work in your drawer at the desk, or have some at home. Have some upstairs, downstairs, in your car, in your handbag. If you're a lady who changes her handbags frequently, then have 2 tablets in each handbag so that you always have covered every eventuality if you're away from home and you have forgotten to take your tablets. Hopefully that should never happen. So then the sick day rules, as we call it, is when to double your dose, and this is what I'm asked a lot. When should I do this? So obviously we teach you to manage this yourselves. So infection is any signs of infection, like a high temperature, a sore throat, sore ears, you're shivery and you feel like flu-like symptoms, then you automatically double up. And as I say, you double up for the time that you're unwell. If after 48 hours you're not feeling better, then you really should be seeing a doctor in case they want to give you some antibiotics. Minor surgery and dental treatment, again, you should be thinking about doubling up. And for certain medical procedures, you will actually need 100 milligrams of intravenous cover prior to things like endoscopies and cystoscopies. And you should always be speaking to the doctors that are doing this and ensuring that they fully understand. Vomiting and diarrhea is a big problem for people that are steroid dependent, and therefore if you are unfortunate enough to vomit, then you should try and take 20 milligrams orally, and if you manage to keep that down for 20 to 30 minutes, then you should be fine. But if you vomit again within that time, then you need to have an injection. Diarrhea, if you have profuse diarrhea when you are running to the toilet and you can't get off the toilet and crampy sore stomach, then double up your dose and you keep that doubled up until the diarrhea has passed, because we are unsure how much of your medication you will be retaining. So if in doubt, take it. Remember, you don't need to ask anybody. You don't need to have anybody's clarification to double up. If you feel unwell and you are unsure and you're thinking, should I take it? I don't know. Should I wait? Then if in doubt, take it. And the thing is, we don't try and preempt whether we need a steroid. You know, I might get the cold tomorrow, I'm going to double up. But if you're starting to feel unwell and you are not yourself, then you will not do yourself any harm to double up. And then you reduce back down to your normal dose when you've recovered. And if you have been extremely unwell and you've perhaps needed to be doubled up for more than 1 week, 2 weeks, even longer if you've been in hospital with another condition, then remember to gradually reduce down. But if it's only been a few days up to a week, then you should come straight back down to your normal dose. And remember, if you're still unwell after being doubled up for a couple of days, then be sure and see your GP in case you need to get an antibiotic. And what to do, unable to take your tablets, then you need the injection. Again, that's something that people are scared of and they don't know how to do it or when to do it. But you're not going to harm yourself if you do take it and your body doesn't completely need it. So there are many places on our website that gives you good information for helping with the injection. And there are also there is a little video clips that you can watch of how to draw up and give the injection, and we'll come back to that a wee bit further on. Remember, I mentioned the steroid card. Hopefully soon we are going to have a universal steroid card that internationally everybody will have the same one. It's with the Department of Health just now, and that will be great for us because then all hospitals are giving and getting the same information. So injectable hydrocortisone, the liquid form that I prefer people to have is the hydrocortisone sodium phosphate, 100 milligrams in 1 ml ampule for intramuscular injection. Now this is what used to be known as F-cortisol. And the powdered hydrocortisone for reconstitution can also be used. You need water for injections, and there's absolutely nothing wrong with that if that's what everybody has. It's just a wee bit more complex for people to draw up, and it's a wee bit more time consuming. And indeed, the majority of people should now be getting taught at their endocrine centres how to self-inject in case of an emergency, accident, or severe stress or illness. And as I've said, on the website there is injection step-by-step training, and I am more than willing to talk people through this on my nurse helpline if they need some help. Or indeed a refresher at any time, because many of you might have been taught how to inject a long time ago. So we move on to adrenal crisis, which is everybody's fear, and also wonder how long before we intervene, how long do you wait? And what I always say, basically, if you've been previously unwell and you have been doubled up your dose of hydrocortisone, and you become very weak, dizzy, nauseous, clammy, you might be sweaty, your heart might be racing, you might feel faint, confused, your speech might be slurred, you might be a bit irritable and a bit irrational, then I would say that these are signs that you are losing your steroid and you have not got enough steroid cover. If you haven't doubled up or you've not been unwell before, then you need to try taking 20 milligrams of hydrocortisone. Again, if there's no improvement within 20 minutes to 30 minutes, or indeed if you are deteriorating, then that is when your injection is required. So it's a difficult one for people. Sometimes you have to experience this feeling and require an emergency injection for you to learn what your triggers are when you know that actually I need to intervene with my injection. But please again remember that you really can't do yourself any harm if you are feeling much worse and becoming generally unwell. If you are not able to do the injection yourself, then phone somebody up and say, I'm a steroid dependent patient, I require my injection. And this is also very important that we move on to traveling with pituitary medications and when you're steroid dependent, because this is a time that scares a lot of you when you are going on holiday, because you think, what if I get a bug or I pick something up? So you can never be over prepared when you are a steroid dependent patient. So I would suggest that you ensure that you have a letter from your endocrine department stating that you require to carry your needles and syringes and your medication with you at all times. If your endocrine department cannot give you one of these letters, we do have a template that we can email you, and then they can fill that out or yourself can fill it out. I say keep all your medication with you in your hand luggage, but also have some spare in your suitcase so that you cover every eventuality. If your case goes missing, you've got in your hand luggage. If something happens to your hand luggage, you have some medication in your case. Please remember, if you're on growth hormone, that this must not go into the aircraft hold though, as the temperature is too cold. We also advise that you take a copy of your prescription. You get a list of all your prescription drugs along with your medications. Take that with you. It's always handy to have. And again, think about your holiday insurance. Ensure that you are covered. And we have a list of insurers on our website that are good with medical conditions, especially pituitary conditions. On our free to download for the hydrocortisone steroid dependent patients, we have the pituitary patient care card, we have a pituitary patient bedside sheet. All of these are excellent for filling in, which keep all your details concise and at hand. And it's very important to make sure that these are updated and have your medications been changed in any way. And now, folks, I think we have come to the end. So I'm sure there will be lots of questions, because our steroid sessions, and indeed knowing by all my helpline calls, there is always plenty questions around steroids. So I will hand you back to Pat, who will help me guide through your answers for you folks, and I hope you are welcome to call me at any time to do with your steroid replacement or indeed any of your pituitary problems.
Thanks so much, Alison. That was really great. We do have a number of questions in. I think we'd probably be able to cover all of them in the next 20 minutes or so. The first question, let me see, it's again about the steroid card. So I think you answered that about the new steroid type card.
The new steroid card, hopefully, yes, hopefully. It is actually with the Department of Health. It will have on it all your details, and it'll have your actual hospital number as far as I'm aware, and it will also be available in many different languages. So it is going to be an excellent resource for our patients.
Okay. The hospital awareness, one of the first questions that the webinar delegate has said, and I'm just saying that your names won't be visible on these questions. This is to keep your confidentiality, and nobody knows who's asking these questions. So the sick day rules for doctors and surgeons and hospitalised, we do have quite a bit of information that you can take into hospital, don't we, Alison?
And to reassure the pituitary community, really, the pituitary patients out there, that all the big endocrine centres, all the nurses like myself, that works obviously for the foundation, but as well as in hospitals, we are all pushing education within our own hospitals and trying really hard to educate people and to set up sort of procedures that means that hopefully in the future the less and less people will be finding that people don't understand what steroid dependency means.
Okay. The question, do buds need doubling up, checking after they've doubled up?
No, not really. Because obviously we know that you are steroid dependent, so if you need to double up, then that's fine. That will help with that episode of sickness or illness or infection or stressful times, and therefore we don't need to look at the bloods. One of the important things, sorry Pat.
Sorry, no, it's fine, go on.
One of the important times that I didn't mention actually about when to double up was emotional stress and bereavement. So normal day-to-day emotional stress, you should have enough with your normal replacement dose. But if you had somebody who died very close to you, then I would strongly advise you to double up your hydrocortisone then. And indeed for funerals of close relatives and friends, then be sure and double up to help you cope with that emotional stress.
Somebody's going for a synapsin test, Alison, and will that help them with their periods of fatigue if they need hydrocortisone?
Yes, it should. So if they think that they are going to be needing to take hydrocortisone, then they should notice a difference with their fatigue. And obviously, if they are still fatigued after that, then the hydrocortisone, if they require it, will be stable, and we'll look at other reasons why they are so tired.
Injecting at home and then still needing to go to A&E to be checked after a crisis.
Yes, I would agree. I mean, the injection is there to keep you safe until you receive medical treatment, not in place of medical treatment. So therefore, if you've had the injection, I think you should always get checked out, especially if you have diabetes insipidus as well as steroid dependency, because you may need to get some fluids. So it is always advised after you inject yourself to get checked out. I know sometimes you think it's supposed to prevent me going to hospital, but what I would say is that it might actually mean that you just go, you spend an hour, you get checked out, and you are sent home. Whereas if you didn't inject at home, it takes a long time to get seen. Sometimes an accident and emergency, you might be 4 hours waiting, and in that time you're becoming increasingly unwell. So it's always advisable, have your injection and then phone and get medical help.
Okay, the EpiPen.
Oh, the bane of our life that we so want an EpiPen type device. Hopefully, I live in hope before I retire that there will be a ready-mixed, ready-to-inject pen for our community. And be rest assured that all the groups that deal with steroid-dependent patients, whether it be Addison's or pituitary, then everybody is always working on this away in the background, and surely one day we will get there.
Does doubling up effectively make you feel better if you have a cold? Will it speed up recovery, Alison?
Not a normal cold, to be honest. If it's a normal cold, when you're just feeling a bit off with it, actually you shouldn't need to double up. And if you've doubled up for any reason and you don't feel particularly better and you're not getting much worse, then you probably can just come back down to your own dose, your normal daily dose. So it doesn't always make you feel much better until the thing passes anyway. I'm just reading to see if there's anything else. I see one about syringes here and needles that may be out of date. I would recommend that you replace these, but if that is the only needle and syringes that you have, then you can use them. They are still in a sealed pack, and they obviously have to be given expiry dates for the hospital setting. But I would say, yes, try and replace these if you can. The next time at your clinic or your GP surgery, ask if they can help replace them. I see one here, Pat, if you come in, if there's anything else that you know of. But I see one about, I've never had an emergency injection, and should I get one from the doctor or the clinic? Well, our advice is that every steroid-dependent patient should be able to inject themselves if they feel able and if they've had training. Then yes, you should have the injection at home. Sometimes some of the consultants say if you live close enough to an accident and emergency department, then you shouldn't need one at home. But we advocate that it keeps everybody safe until they get medical attention. But remember, not all people are indeed able to inject themselves. They feel it's just too much, and they feel very unwell at that time and wouldn't cope with the added addition of having to give themselves an injection. So in that cases, then it's acceptable not to have the injection at home. But if you feel that you are able to do it, it keeps you safe and it gives you peace of mind. Many people don't need to use it all the time. In fact, many people don't need to use it at all.
The question about more awareness now with staff in A&E. I think the paramedic awareness, so if you were to phone an ambulance to get to A&E, but certainly in A&E itself, I do feel as though it's improving, and we are working with paramedics in A&E to improve awareness.
I think so. And we're certainly trying. In our hospital, we have the system when we put in your CAI number, your hospital number, and up comes your name. We are trying to get an alert on our track here for all our patients so that when somebody types in Pat McBride or Alison Milne, it would say, please be aware. We've got, so hopefully more and more hospitals will be adopting this as well, and that will make the awareness better. What I will say about the injection again is, remember, if you do have it at home, you're speaking about the syringes being out of date, always remember to check your ampules and the expiry date and write it on your calendar or put it into your phone and flag it up. And another good way for raising awareness for people if you're feeling vulnerable is if you have an iPhone, there is a medical ID part on your phone that you can get to even if your phone is locked. And if you make sure that that is filled out with all your details, then in the event of an accident or you passing out with nobody that knows you there, then people can look on that, and certainly lots of people are aware of that.
And the long flight doubling up.
I was just reading that.
Yeah.
Mm-hmm. So what I would say, you don't really need to double up unless you're a very anxious flyer. But what I would say on a long haul flight and when you're changing time zones is that you take your hydrocortisone every 6 to 8 hours so that you are not going longer without your hydrocortisone until you are in their time zone and going to bed at night and getting up the next morning. Does that make sense, Pat?
Yeah. Yeah.
Yep. Okay.
And just a few more questions now, Alison, and then we'll have to start to close this up. But the child of 2 years old with carers and the clear signs of adrenal crisis.
Oh.
So in a child.
It's hard in adults, and it is very hard with children as well. But what I would say, if they hopefully know your child, your daughter, is it? Hopefully they know the daughter, then anything abnormal, if she is starting to get a bit sleepy, weak, floppy, not irritable, possibly with a child might show it. And their colour, I would imagine as well. Their colour may change and their eyes may just go a bit like they're away. They're not really paying attention. So it is a difficult one with children, and I suppose they change very quickly as well. But to reiterate to them that they are not going to do any harm. It is always better to treat than not to treat when you're thinking about emergency hydrocortisone.
I think finally the red flagging issue at the bottom there. We do know from the Foundation campaign that the only area of the ambulance services who aren't involved with this or won't be involved is Yorkshire. I think I'm right. But we do send out red flagging fact sheets, and by and large we have had good successes. And what could you bring to that, Alison, about not all ambulances carry?
Yeah, I think not all ambulances do. You're right, they don't all carry it and they can't all inject, and that is why if you have a consultant or a GP that doesn't want you to have the injection, that is another argument that you have. Then because the ambulance might not have it, I need to keep myself safe. And also, and that is the reason why, we say give it at home. Even if you've called the ambulance and you're very unwell, I wouldn't just expect them to give it to you. If you can give it to yourself, give it. Then in the time that you're getting to hospital, it'll help keep your blood pressure up. It'll help stop you from going unconscious in that time. And therefore, you might only have a couple of hours at hospital to get checked out and sent home, as opposed to a 2 or 3 day admission. And the other thing I would say about the ambulance flagging is, remember that you are flagged for your home address. So if you were unwell in a different area, you wouldn't be flagged on everybody's ambulance system. It's only your home address. I'm sure I'm correct in saying that.
Yes. Yeah.
Okay. I'm just going to wee look to see if we've seen anything else.
The extreme fatigue, the bottom.
Once you've drawn up an injection, how long is it viable for in the syringe? Well, you shouldn't be drawing up your injection unless you're giving it, okay? Because it wouldn't be law. You can't draw it up and leave it sitting ready for just in case. Okay, that injection is made to give. You make it, you draw it up, and you administer it. You don't leave it lying in the syringe. Okay, so we wouldn't advise that.
And the fatigue question?
Where am I?
The bottom.
Yeah. Extreme fatigue, even if you double up and it makes no difference, well, that tells me that probably it's not, the steroid isn't needing doubled up, that maybe there might be something else going on that's not an infection, that you don't actually need to double up your steroid on that day, because if it isn't making much of a difference and this extreme fatigue, then extra hydrocortisone won't help that. Perhaps we need to look at your blood levels of your other replacement hormones. And remember, we all have days as well that we're tireder than others. But the extreme fatigue does need to be looked at to see if we can help in any other way. Is there anything else coming in, Pat, that we might be able to help with?
Get flagged with the ambulance.
Yeah.
This might be a different, slightly different process. But certainly I would suggest that we send you a red flag fact sheet to see if that would work if you speak to your GP.
And remember, I'm more than willing to go over the sick day rules with people, at any time when I'm on my helpline. I can help with that along with our information that we have. And I can't stress enough, you can never over-prepare with being steroid dependent, and the more information you have to pass on to your healthcare professionals, the better it will be for everybody in the long run.
Right, I think that's all the questions there, Alison. You've answered a great deal. Thank you so much once again.
Okay.
So you can always speak to Alison on the phone. Her number's on the website, or you can email the helpline. And we have 2 further webinars confirmed. One is in June the 22nd, with Professor Newell Price on Cushing's. And on the 27th of July, we have Professor Peter Traynor talking about acromegaly. So I hope everybody's enjoyed Alison's webinar, and thank you very much to Alison, and thank you all our members for joining in.
Thank you. Keep well.
Okay. Yeah.